What's up, guys? Welcome to the PT Good podcast, where we talk all things ortho, from physical therapy to training. My name's Kane.
And I'm Mark.
All right, Mark. So what is on the agenda for today?
Okay, Kane. We got a good topic today. We are going to be talking about motor control. And, it might mean different things to different people. People may have different ideas of how it's implemented or, just what it is. So, Kane, why don't you start us off with a definition? What is your definition of motor control?
All right. So to me, motor control is two different things. So the first one that it can be is if you are treating something that is either proximal or distal to the affected joint, and you're able to create change at that problematic joint. So if you are, for example, someone comes in with knee pain and you treat either their hip or their ankle, and you end up changing symptoms at their knee, that to me would be considered a motor control issue. The second one would be if you are changing a pattern or a sequence to improve on their quality of motion or their muscular recruitment, and that ends up changing their symptoms at the joint. That could be a little bit where you're taking some of the stuff from the first part of the definition. But yeah, if you are changing their quality and you're noticing that their symptoms are changing as well there, I would also say that that would be considered motor control, at least to me.
Okay. So before we talk about it more, like you talked about, how do you implement it, right? I think if we get just give us maybe an example or what does the implementation of this look like? And then we can start to build off there, look at examples and talk about it more.
Yeah, so different examples of this. I think we've alluded to it, but we haven't fully explicitly stated. But the order that I usually will go in is checking mobility first, restoring that. Is it still problematic? Did anything change, right? Mm-hmm. And then the next thing that I usually take a look at would be motor control. So, like I said, the example that I usually use is super easy to see, and I think it's a pretty common presentation. Whether someone else considers it to be a motor control intervention or impairment is a different story. But for me, it's if someone has knee pain and I do a couple of different exercises for their hip, whether it be for their abductors or anything along the lines of that, or even their extensors, just getting their glutes to kick on better. And that changes their pain at their knee. That would be one of the ways that I would address it.
Okay. So you said kick on. So let's take that example, right? They have knee pain. You're addressing more proximal joint being the hip. And like you said, glutes kicking on better. What do you think? Do you measure that a certain way? I think most people understand where you're going with it, right? It's okay, you have, and even we have research to say, depending on the kind of knee pain, if you address more proximal, hip extensors, abductors, external rotators, things like that, you can see benefits in knee pain. Do you find that when you're addressing the more proximal joint, in this case the hip, and you said glutes kicking on better, what does that mean to you? Do you measure it a certain way? Do you look for anything specifically, or is it just a symptomatic response?
So there's a couple of things I'm typically looking for. I'm definitely not measuring this. This is not. I'm not stuffing someone with electrodes or something like that to see if something's changing mid-session. I feel like that would be a little bit intrusive. But the usual thing that I will do is I'll observe the quality. Does it look okay? Does it look pretty? Right. And like we talked about previously, I'm not someone who's just everyone has to have this ideal way of moving. It just doesn't make sense. But if you're coming in and you've had these issues, maybe like I said, I'm someone who typically just lets people move the way that they need to move. But if you've been moving like this and it's been problematic for you, hey, maybe that's the problem. So let's make some adjustments. Now, when we give some of those cues, do we get a symptomatic response? Okay. So if we get a symptomatic response, that's probably telling me, hey, if we clean up some of your movement, then we're at least heading in the right direction. That's awesome, right? The other thing that I'm looking for is, and I'll usually palpate this, is to see when and what exactly is kicking on, or like the sequencing of it, right? So one of the things that I'll usually check on eval too is if I check a hip extension, if they are utilizing their hamstring first and primarily versus their actual glutes. And I'll check that both like in a glute / hamstring bias to see which one is being emphasized more. And one of the things that I notice is for a lot of patients is, especially the older patients, is they really don't use their glutes. They kick on their hamstrings primarily, and that's where a lot of their hip extension comes from. And so when I notice things like that, if I check the glutes directly and try to isolate it more, and that appears to be like weaker than when they're allowed to use their hamstrings, that kind of tells me that they're not utilizing their glutes quite as much, or they just don't know how to get them to function a little bit better when they're actually doing a functional pattern. So those are the main things that I'm usually looking for, is like their quality and then their sequencing as well too.
Okay, so what if someone, and I think this is where the term motor control and the way it's implemented gets a little bit of, bad reputation, is that like you talk about palpation and muscle sequencing and stuff like that. And it's kind of like we have multiple layers here where it's, a little hit or miss if these things are, if they're relevant, if you can reliably detect these things. So like, what if let's start with, you mentioned palpation, and I know your overarching thing is like you said, quality movement, which is like how it feels to the person, the symptomatic response, right? So you're doing these things. Like, how much value are you putting into what you're palpating, the sequencing, stuff like that? Or let's say it's someone like you're looking for them to be able to use their glutes more in a certain movement, and you have them do some glute exercises, and their symptoms are better immediately after. Like, are you still going to, palpate hamstring, palpate glute, have them do a certain movement, and then look for that sequencing? Or if you get the symptomatic response just with them doing something in general, you're going to roll with it. Which is like kind of what I'm trying to get at, because it's kind of right. I mean, like I said, I think the whole motor control thing, it's like, to me, and the discussions we've had already, it's like it kind of, it makes sense. I understand how you're utilizing it, but is it like, how much value do you put into, like I said, assessing the sequencing, the palpation, things like that?
So much, dude, everything is based on if something is kicking on appropriately. Like, my hands can feel all of it. No, I do not put a lot of stock into it. I use that for my initial part of my assessment, and that's about it, to be honest.
Okay, gotcha. Yeah, that's because like. Okay, I'm glad you said that. Now I can. Now I'm gonna have a good day now. I was getting worried. Okay,
so
yeah.
The big thing is, like, you are utilizing these things to change your patient's symptoms, to change their pain, to improve their function. That takes precedence. I don't care how good you think your hands are. If you are not prioritizing that, then I think that you're kind of missing the boat. Right? Because it's if someone moves and they don't have pain, that's okay. If you've made improvements, maybe that's all that they needed. Maybe they just needed a cue, or just to, I always tell my patients this, but it's to help bring awareness to that area.
Okay. So maybe you're palpating and it's like, hey, I think you're using this muscle more than this one. What if you did that movement and you try to use this, muscle in the back of your hip to pull your leg back? It's something as simple as that, or does it become more detailed, or
not typically?
Yeah,
like to be fair, like I've worked in as a strength coach and as a personal trainer for quite a few years, and so I I can have a pretty good eye for how people move and like what it should kind of look like, especially for each person. It's not like one person is going to move the same way as everyone else. So just seeing
Right.
how they move, seeing their level of coordination and where they're at and what their common strategies are. Like we talked about this previously, but I think it's something that could definitely be fleshed out more, which is the fact that movement and like all these patterns that we go through, they're all skills that you need to practice. And so if someone isn't as like physically capable of doing something, like that's okay. They're going to rely on different strategies. And it doesn't mean that those strategies are wrong. We just need to kind of make do with it and work with our patients in that regard. But if someone demonstrates really, really high levels of movement, I'm probably not going to have to worry nearly as much about like their motor control or their sequencing or any of these things for lower level activities. For higher level stuff, sure, but definitely not for lower level stuff. I would say just because they understand how their body moves, they understand like what's kind of contracting, what's not, and like what should be working. Like I'm sure that a lot of people can probably relate where they have a patient and they're moving super well. And then you ask them like, hey, do you feel this here? No, I don't feel anything. You're just like, wait,
Yeah,
what muscle do you feel is working? What's getting tired? I don't know. I can't tell. I'm just like, so for those people, I have to rely a little bit more on like what I'm seeing and like what I may be feeling versus what they're feeling and able to communicate that with me. And that's totally fine. And especially like the simple question that you can ask is just like, hey, is this reproducing your pain? When you retest, hey, does this change your previous symptoms that you had? And if it does, awesome. That's kind of the end of the discussion.
yeah,
It really doesn't need to be a whole lot harder than that.
yeah. And I think you've or we've talked about before, like even in the absence of pain, like you talked about from a performance standpoint, like, hey, you're doing this movement in a certain way now. How's it feel for you? Are you able to perform? Are you able to do the task that you want to do at the level you want to do it with as you're moving this way? And listen, maybe this person doesn't have pain, but if they're concerned from a performance standpoint, yeah, you can, you want to tell us, like, can you look at how you implement motor control in that regard as well?
Could you restate that question? I didn't.
Yeah.
Quite
So like, what if
understand, like,
someone,
what you meant.
yeah, someone comes in, they don't have pain, right? But their primary concern is like, hey, when I squat, I don't feel, maybe that, I don't feel strong when I squat, right? So for an individual like that, when they don't have pain, they're not symptomatic per se. Can you
Oh,
implement motor control in that regard?
yeah, for sure.
Hmm.
I don't know if I would necessarily consider it motor control at that
Hmm.
point. It kind of depends on how they're presenting. But like, if someone comes in like that, my first question would be, like, how are you squatting first and foremost? I won't
Right.
bias
Yeah.
them in any way, shape, or form. I'll just see like, hey, how are you moving? And then I might check out a couple of other patterns to see if they coincide. They usually will, because a movement strategy usually is like a principle. It's not like you only do it for one pattern and that's it. It's usually
Hmm.
across the board that you see a compensatory pattern, or just like what their movement strategy is like as a whole. Now, once you see how they're moving, then you start to kind of assess it. Okay, what's the quality like? What are they biasing? Like what are they utilizing more? Are they someone who, like, if they come to me and they're like, oh, I don't feel very strong when I'm squatting, even if you take like someone who's like in their 20s, 30s, 40s, anything like that, they're a gym goer and stuff like that. But if I see that they are like completely pitched forward and they're like, yeah, I just don't feel a whole lot in my quads,
Hmm.
maybe you can change that, right? Maybe you can cue them to be a little bit more upright. Maybe you give them a dumbbell to counterbalance them so that they can maintain a better position, and then see, okay, now that we've changed your torso angle, that's going to bias your quads more. At least it should. What do you feel here? right? And when you do that, that should make a pretty substantial change. And then vice versa, if someone's like, oh, I feel like I can only feel it in my knees when I squat, and you see a whole bunch of anterior knee translation, their heels are popping up off the ground, and you can see like that they are having a hard time controlling their torso position because of that. You may have to address a couple of other issues. You know, maybe it's their ankle that's not letting them get into an appropriate depth in their squat, or maybe you have to work a little bit more on their hips so that they can control their knee a little bit better and improve on some of that tracking. So those are a couple of things that I'm typically looking at when someone's like, oh, I don't feel strong, and then see if anything changes there. I forgot. There's one thing that I usually will add in before all that, which is asking them, when you say you don't feel strong, what doesn't feel strong? Like, what do you feel when you're squatting, when you're lunging or going up and down a step? Do you feel like your hip is working? Do you feel like your quad is primarily moving? And I can almost guarantee you, like 80-90% of the times, it's that their quad or their knee, quote unquote, according to the patient, is what takes over, and that's all that they feel. Because most of the times, like, quads are just so strong, they're going to take over. But your glutes are your powerhouse. If they don't do their job, if they aren't as strong as they should be to meet with the demands of the activities that you're performing, that's when I'm like, okay, you're probably going to run into some issues here. Like I cannot think of any single athlete that is strong, fast, powerful, that does not have a set of glutes where they look like they are caked up to the nth degree, where they can open up a bakery. Like,
so you in that regard, you'll use a strictly visual assessment.
Yeah, like their quality for their quality of movement.
No, I mean in terms of like their glute development.
Yeah. Oh my god, I'm dead. Okay. So for some people, you definitely can. For like for athletes and stuff like that, you're just like, wow, okay, they got some legs.
They know how to use.
Yeah, so like you can really, really tell, and especially for their patterns too. You know, they just move so differently, and I get that it's subjective, but at the same time, it's just such a hard thing to ignore. Where I'm like, okay, like if you're built like a horse, I am pretty likely to be like, okay, he's pretty strong, you know, and they could be a bodybuilder, they could be a sprinter, they could be a football player. Regardless, you spent some time in the weight room, you spent some time moving heavier stuff and like learning how to move your body. And that's really kind of the baseline for where you should be for knowing how to perform these motions.
Yeah. And the one important thing I wanted to acknowledge and point out, especially when you were mentioning like when we talked from a performance standpoint, there wasn't any specific movement like you should move this way. This is how this should be done. You assess the movement, you try and every time you mention making any kind of change or implementing any kind of exercise, whatever it may be, you use the word maybe. It's like maybe we'll do this, maybe we'll do that, maybe, right? So at least from your standpoint,
have no
there's
idea.
Not. Yeah, exactly. It's not like someone comes in and like, oh, hey, I don't feel good squatting. Okay, this is how you should squat. Shoulder width, feet pointed out a little bit, right? This is right. It's all base. You have to contextualize it within the task, the individual, what they're looking to do, and then like because I think sometimes with motor control, people think it's something where it's teaching someone how to do a movement correctly, right? Where that correctly wasn't in your definition, right? Even when you explain it within these examples, it's more so like implementing a change to reduce pain, help the person, move better, perform a task better, right? So there's some nuance to it, right? It's not just a strict set of rules. This is how you should move.
Yeah, it's not a cookie cutter pattern. And I like when you said that I explicitly made sure not to say that it is the correct movement pattern.
Yeah.
Instead, what you can say is the correct movement pattern for them, which is totally fine. Someone who is like 6'8" is not going to move the same way that someone's 5'5". Like your limb ratio is going to affect how you move. Your torso length is going to affect how you move. Whether you're male or female is going to affect how you move. Like shoving people into this cookie cutter pattern drives me insane, because it's just I don't know how else to put it. It's kind of just a lazy approach, or you just don't know how to troubleshoot through that. Like I'm not saying this as in like oh, it's really, really difficult and complex and not a whole lot of people can do it, but it's maybe something that we haven't spent as much time doing it, and it's something that I've had to spend too much time probably doing previously, where one of the things that I when I work with my athletes, and I see this all the time previously, is like they're athletic. They know how to brute force things, like they know how to perform. But my job as a strength coach is to make things more efficient. Can we make you more powerful? We make you, and this is to me the most important part, can we make you more stable when you are performing these motions? If you are more stable, guess what? You can inherently create more force. Your body likes stability. So that is one of the questions that I always asked when I was helping someone with their performance. And now I still continue to ask is, do you feel more stable? Do you feel more powerful? Do you feel like this is better than the previous version that you were doing? Yes or no? And those answers are kind of what help dictate and guide you on whether or not you're making the appropriate changes. And when you're making these changes, I really, really want to emphasize, do not make huge changes. Do not like force someone to significant degrees of like Varus to ensure like this picture perfect squat pattern. Change one thing at a time. Move your feet out a little bit wider. See how that feels. Oh, that doesn't change anything. Try squatting again, and then just try pushing your knees out a hair. Maybe just give them a cue. Don't let your knees touch my hand. Leave some daylight in between your knees. If you're seeing significant valgus there, okay, maybe that's not the best thing for them to do, especially if it's like an older individual. They've been squatting like that for a long time. Consider like your like 70s, 80s female typically, where they're having more and more difficulty getting up and down from a chair, and they're starting to do that, or they've been doing that a lot more. Maybe you make a couple of adjustments to their knee position and just go from there. You make one small change, and you recheck. That's it.
Exactly.
Don't make sweeping changes, because you have no idea what actually worked and what fixed it. And on top of that, if I don't want to move my patients too far out beyond what their natural pattern and what their movement strategies are. It just doesn't make sense to me. Keep them within like where they can still apply some of their movement pattern strategies, and see how much more you can make it like efficient. And if that's the case, usually you'll start to notice changes that start to stack up. I'm not looking to be like, oh, we completely got rid of your pain, but instead it's getting better. It's still getting better and better and better. Awesome. Now we get to see where exactly we need to be and where we call it when it comes to motor control. It just doesn't make sense to like beat a dead horse when you're cueing someone on this. Sometimes once they have learned and once you've taught them it, just let them move and continue to figure it out themselves.
Yeah, exactly. Yeah, they'll understand. Once, like you said, once you cue them, once they get the idea of how it feels when they're, you said, more stable, moving better, performing better, they can, make minor adjustments on their own. Especially this is compared to, let's say someone comes in and they're squatting, they don't feel too good, right? You notice they have a close stance, feet pointed straight forward, something like that, right? Maybe someone's would want to make a bunch of changes right away. Hey, move your feet out more, point your toes out, maybe point your toes out more, do this, hip slack, blah, blah, blah. Rather than what you said, small changes to start with, and then you can start to add from there. Maybe you just start by widening their stance a little bit. And like, hey, that feels a little bit better. They run with that for a little bit. You can things like you said, they start to build upon each other, and the person will be able to identify and figure out what feels good to them.
There's one more aspect of motor control that I forgot to mention, and this is something that I typically see for people who are post total joint surgery, or just like older individuals in particular, which is like eccentric control. Most of the times, like if they are doing, like if they're squatting or doing sit to stand in particular, where they're, my knee really gets me, I just don't have that strength anymore. And you see them come up and down and they flop. You see it all the time in the clinic, right? That flopping motion, they just really struggle to keep their torso position and to actually keep their quads and their hips engaged when they do this. So having good quad eccentric control, or just control in general, is going to help them be able to use their muscles a whole lot more, instead of just like letting gravity take over and just shoving their body wherever it needs to be. Like I usually tell this, especially for my athletes, but it can apply for Gen Pop as well too, which is your body is only doing what you tell it to do. It isn't like this, like it has its own mind where it just does things on its own. No. You control exactly what it does. You have that ability to do it. It's your job to be precise with your movement. And like, especially for athletes, if they're cutting, if they're jumping and landing, you have control over where you're landing, how you're landing, the distance, the height of things, the force that you're going to produce, etc. You need to be pre-planning these things, because that is motor control, that is coordination. These are going to improve on your movement pattern strategies, right? So if tying that into for Gen Pop, and just teaching them, hey, you don't need to flop, you can control this, it just takes more effort. And when you show them this and they're like, oh, I don't have as much pain when I do this, I feel better when I do this, it's like, oh, okay, so now we're cooking. Now we know that maybe we work on more eccentric loading in these patterns. Boom, done. We pretty much just resolve something without having to change any pattern whatsoever.
Exactly. Yeah, so again, another example of, this is how you're moving, this is how I think you can do it better. And implementing that change, rather than saying like, hey, this is exactly how you should do it. It's like, hey, I noticed that you said you're doing this when you sit down, it's not as controlled, you flop down. From, for whatever goal you're trying to achieve, you're implementing this change, but it's not a, throw everyone into a single box, this is how you should do things, and, you can't do it any differently.
Yeah, for sure. I feel like the whole, like, cookie cutter, like ideal movement pattern, it just doesn't work for people.
So why do you think people, and I'll speak more generally here, just based on my experience, I mean, last week I witnessed this in the clinic, like people still like, hey, when you squat, like this is what your knees should do, and they shouldn't go this far forward, and when you do this, and it's just, do you think it's just, is this still what's taught? I mean, at least, I wasn't taught this, or maybe I had this understanding before school, so I blocked it out. But like, why is this still? And I think this is a reason why the term motor control gets. Partly why it gets a bad reputation is people think of motor control and they think of people telling people how to do a movement without any kind of context, right? So, do you think, why do you think a lot of PTs are still, not really contextualizing movement, just kind of throwing it in there? It's just like, this is how you should squat, this is how you should pick things up, this is how you should sit down in a chair, move your arms, stuff like that.
I think a lot of it is just what's been taught to people and hasn't really been explored or pushed any further. Like I usually make this comment to Mark when we have our normal discussions, but like I usually say that people haven't pushed the information to its limits yet, and that is really exploring the nuance and the context of it and how it applies. So like I feel like, to answer your question, Mark, it's a lot of these like tips or recommendations that people have been things that have been recommended for a long time and have been taken almost as gospel. And this is how you're supposed to move. If you don't move this way, this is when you have issues. So it becomes a little bit of a misunderstanding. There's also, I hate to say it, but some fear mongering as well too. Where I'm like,
sure.
It's okay to move. Like, it's fine, right? You've probably heard of not squatting so that your knees go past your toes or anything along the lines of that. Some people are like looking at shin angles and they're like, oh, no. You have too much of a forward shin angle to the point where some people have a negative shin angle when they squat. And I'm like, whoa. You're literally going to fall.
What are you doing? And it's always there's some need to when someone as a patient come in and they squat and knees past their toes, which is fine, and the patient says, yeah, it feels fine, I can do that, and then the PT is the patient literally told you it feels fine, and they're just like, oh well, your knees really shouldn't do that, it's too much strain, you're gonna have bad knees, it's not healthy for your knees, you're gonna wear and tear in the joint. And it's just such an odd, to me, it's such an odd and awkward interaction where someone tells you something feels good, feels fine, they can do it, and then you just come back and tell them, no, you shouldn't do that. Just weird.
Like, I get the whole, if something doesn't look the way you might want it to, and you're trying to prevent issues from happening, I get that. Mm-hmm. But what if you look at it from the flip side? What if you change their movement pattern and what was fine is no longer fine, and you create a potential issue down the road? Like, we talk about potentially preventing shoulder issues if they have like scap dyskinesis or something. Mm-hmm. And then, but like, what if it's the other way around? And that's where I have a problem with that, because it's like, you just haven't spent enough time utilizing this concept yet. And I don't mean as in like sheer experience with it, because people could have been doing this for several decades and just not grown from it. But instead, pushing that information and seeing, hey, oh, this is a person of a different body type. Maybe they need to move a little bit differently than what the average person does. That's totally fine. That's very appropriate. Maybe they do a different sport or have different needs and demands. And going from there, okay, awesome. Now we can see that there's that obviously some of these movement patterns can be more tailored to an individual. Like, that's the biggest thing, is you should be tailoring your care to the individual that's in front of you, not stuffing them and pigeonholing them, and saying, oh, you should be moving like this, and this is what's going to fix it. Not necessarily. This is what drives me nuts, because
go ahead.
I was just going to say, it's like, when you have movement strategies, it's important that you let your patient discover, learn, and implement them themselves. Like, it's your job to guide them there. And they need to figure these things out.
And you're equipping them with the tools to do so. I mean, we can tie this back even to some of our previous discussions when we talked about just addressing pain from like a test-retest standpoint. Like, it's kind of right. They should know how it feels. They should know how to adapt, how to change things. They have an idea of how to figure things out on their own. And like I said, you're looking to help the individual within the context in which they have to move or perform a certain task, or just reducing their pain. It's not something that, oh, this is how you have to do things, right? They should get an understanding of when they can move differently and have ideas of, how to adapt and change movement to, do what they need to do.
Yeah, I think that's so important too, because it's just like, you empower these people to start to question and be more active in their in their own like actions and participation in life, where you're like, okay, maybe you start to give them, or like you probe them for like how they're sitting down, how they're getting back up, how they're going up and down steps and stuff like that. And then they start to actually explore and think about it. They're like, oh, I like how this feels. I don't like how this feels. Okay,
Yeah.
move away from it. Try this, try that. And then the thing is, as PTs, you are equipped with all of these tools to know how to kind of guide someone, right? Like if someone's going up and down a step, they're like, no, I feel it a whole lot in my knee right now. And it just doesn't feel good. It's like, okay, so what can we change about that? Do we change your torso positioning? Do we change like how you're going, like how you're kind of planting and going up? Do we focus on controlling your knee? The patient's not going to know this. They may not think about it until you introduce that concept to them and you get them to start thinking about it. You start guiding them to that realization of like, oh, this feels good. I can do this. And
Yeah.
they start to realize that your job is not you telling them the right answer. Your job is to help refine things and get them closer and closer to like, oh, this is what works best for me. You know, like
exactly.
you can't exactly provide them that answer. They have to discover it.
Mm-hmm.
And that is the thing that I think that a lot of PTs fall in this trap under, where, and I mean, it's like most medical providers, they want to find that answer and to provide that answer for their patients. And I straight up tell patients like, hey, I don't always have the answer directly for you, but we're going to help you find it together. And that to me is a lot more empowering because they understand like I'm collecting data from them so that I can narrow down like all the things that we've worked on. I'm like, okay, this doesn't work. That doesn't work. Okay, we'll just get rid of it. These things do. Let's focus in on these and then continue to improve on it.
Yeah. Like you said, they don't, all the patient is coming in is, hey, my knee hurts when I go downstairs, right? It's just kind of, hey, but a couple months ago, and for as long as I was alive and doing stairs, it didn't hurt me before. So then it's up to you to be able to, hey, yeah, exactly. Like you said, help them realize like there's different things you can do to reduce those symptoms, eliminate them, and then manage them going forward. Not that, hey, this is exactly how you have to move, but hey, maybe if you do this exercise and maybe when you go up, if you use your hips a little bit more, lean forward, and you distribute the weight differently, it might not bother you as much. And you don't always have to move like this in the future, but it's an option if your knees bother you. And within that approach, like you said, there's not a diagnosis, there's not a anatomical answer per se, but there's a solution for them, right? In terms of, hey, look, I just showed you that if you do this, your pain goes away when you do stairs now. Now it's up to you. This is something you can implement whenever you like.
I think that feedback loop is so strong because no one likes being in pain, and so when they do it, they're like, "Oh nope, I did it this way," and they're like, "Yeah, I felt it." I'm like, "Yeah, okay," and I'm like, "How do you fix it?" And then they usually correct it, and I'm like, "Does that feel better?" Yeah, it feels better. I'm like, "Does it feel like how it did previously, like when I first helped you?" And they're like, "No, like I can get there." I'm like, "Okay, show me what that looks like." And they make a couple of different micro adjustments, and they're like, "Oh no, now it's gone. Now it's exactly how it felt like when you showed me." I'm like, "Awesome!
Like,
now
cool.
You can replicate it."
And do you ever use like the when I implement these kind of things, and we probably implement this strategy similarly. It sounds like from what you're telling me, it's similar at least. But I'll tend to use this explanation just to give them some kind of explanation. Like, hey, let's just say going upstairs, for example, right? It's like, yeah, and it hurts my knee when I go upstairs. Okay, how about if you lean forward a little bit more, and then you're getting a little bit more of a hip extension moment, and use the glutes a little bit more. You're giving them some hip exercise. Oh, it feels better when I do this. An explanation I'll give is, hey, you lean forward a little bit more. You're to some degree, you're offloading the knee joint because you're shifting your weight forward. And maybe over time, as they do that, it just calms the knee joint down. Maybe a month later, they can do the stairs how they were doing it before without the small adjustment you made, and it doesn't hurt. Like, is that an explanation you ever give? Is that something that's in the back of your mind? Like, hey, we're just giving this a joint. We're offloading it slightly by changing how the person's moving. We're giving it time to recover because for whatever reason it's irritated. Do you take that approach at all? Like, do you give them any kind of, explanation in that regard?
That is actually something I've never considered.
Wow.
That is a very, very good way of introducing someone to a concept like this.
Yeah, so I have
someti-
some other examples of it too, but yeah, go ahead. I can talk because this is something like I don't tend to use the term motor control. To me, it's more like how you said, like with like joint derangement, hypermobility. Like for me, motor control to me is like if it's in regards to pain, I find it's more so like taking stress off a certain area and then training that joint in that quote unquote less stressful position and letting it calm down and then just exposing it and then just gradually, getting back to how they were moving. Or hey, now it doesn't bother you, just move however you want. But yeah, what were you gonna say?
to be fair, and like we should dive into like what your perspective is
Okay,
on this as
yeah.
well too. But like to be fair, I don't explain it that way, and that's actually a really good way of doing it. But I think in the long run, that is ultimately where we both end up.
Yeah,
Because
sure.
people aren't going to be constantly thinking about this once they start to feel better, right? Like people don't think about how their body feels really when they're pain free. They're just like, oh yeah, it feels good. Like
Right.
it's fine.
Yeah,
I'm just
yeah.
going to keep doing what I'm doing. So when you get rid of their pain, when you teach them how to move and do some of these strategies, sure, some of it is going to stick and it's going to stay there.
Mhm.
Some of it is not going to. They're
Sure, yeah.
gonna default to some of their patterns that they've been doing for 50 or so years.
Yeah, and maybe it's not
right?
important that and maybe that's fine. Maybe that's expected, right? Which is
Yeah.
kind of what's in the back of my head, right? It's not like, hey, like, yeah, like I don't know if you expect people to, unless maybe the performance aspect it's different, right? But if we're talking about pain, maybe it's not like, hey, for now, I want you to do this task like this so it doesn't hurt as much, and then in the future, you just do it, whatever. Don't even think about it. Do whatever you want.
That's
Maybe.
probably where they're gonna be though.
Yeah,
Like
exactly.
aren't gonna think about it. So like I
When they don't
like
have pain,
your thought
yeah.
process. Yeah, I definitely like that thought process. It's not something I I tell my patients, but I know that that's what they're gonna do, and
Yeah.
I think that's totally fine. Like you're gonna get to a point where you feel good, and you just don't think about it, and you just move. And like I said, part of the pattern that we've worked with them to help discover, they're going to utilize different aspects of it, and then they're going to use different aspects of their previous movement strategies, and they'll be totally okay with it. Maybe what you did was just enough to get that tissue to calm down, just like you said, and the strategies that you help to give them, that is enough for them to continue living their life pain free, and that's awesome. Like I don't want you to constantly be thinking about how you're squatting every single time you get up and down from a chair. That just ruins your life. It's just pervasive. Like you shouldn't be thinking about that.
I'm always thinking about cane now when I stand up. Yeah.
So like that's not what I want. I want you to do your normal day to day and be like, oh, I got up, no problem, cool, I'm gonna move on with my life.
Yeah, exactly. Yeah.
All right, so we talked a whole lot about like what my thoughts were and how I kind of approach and implement this, and you discussed it briefly, but what is your typical utilization of motor control, or how do you implement it, or like any other differing philosophies or principles in regards to it?
Yeah, I think we probably implement it similarly. Just like we had clarified earlier, like the you talked about palpation and sequencing and stuff like that. Like I don't, when I'm addressing, let's just say motor control, like I've exhausted directional preference type things. This is kind of where I go to next, and I guess I don't really term it motor control. We can say it's motor control for the sake of this episode. I don't use the term personally, but essentially what it looks like for me is let's just someone has pain, and it can even be like within that joint. So let's shift from me. Like one thing I'll do, let's say they have like medial ankle pain, okay, and they only notice it when they walk, or maybe when they go to shift their ankle from like the brake to the gas pedal, or when they go to stand up from sitting. And I said I've exhausted repeated movements, sustained positions, all that kind of stuff. So now I'm looking at, okay, what's happening that they're having this pain? And they've told me they only have it, when they turn their ankle, when they go to stand up, when they walk. Okay, show me how you're doing those things, right? And I just, it's more of a biomechanical approach, but then I'm looking at them and they're walking, and compared to their opposite side, their ankle, like when they're standing, is a little bit more everted. They have, I'm suspecting they have more strain on that medial ankle. So I'm thinking, okay, maybe this is causing their symptoms. So you talked about addressing the more distal or like proximal joint. To me, I'm like, okay, let's see what I can do with addressing this joint specifically. So if I'm thinking that they're a little bit pronated when they're standing or walking, I say, okay, here, I want you to stand again. And when you stand, let's just do like an arching type exercise, right? So I explain that. I have them build that up. Maybe I have them maintain that when they're in like a single leg stance. I have them go into a lunge with it, right? And then when they're walking, I just have them practice that, right? And if they say, hey, actually, when I do that, I don't feel that as much on the inside. And then maybe over time, they have offloaded that medial ankle enough that it doesn't bother them. And then I'm like, okay, hey, let's cut the frequency of the exercise in half. I don't want you to think about it when you're walking anymore or when you stand up. And then I have them walk around the clinic, and, they look, their foot and ankle looks similar to how they were walking at the evaluation when they were symptomatic, but now they don't have symptoms. So then in my mind, that joint or that structure, that soft tissue has become less irritated to the point where they can move how they were moving without symptoms. And then now they have an idea, oh, hey, when this was bothering me, I did this exercise to take some stress, take some load off this part of my ankle. But now that I don't have symptoms, I don't need to offload it, or I don't need to move like that anymore. I can move how I'm used to, which you talked about previously. The person's probably going to default to the movement strategy that they've been doing for a longer amount of time. So I don't expect them to, and I explicitly tell them I don't want them to always be thinking about how they're moving, unless if they have similar symptoms to become symptomatic again, they know how to temporarily alter or change their movement to take some load off that structure. I said, this is all, it's a little bit more biomechanical. It's all kind of like hypothetical, but the baseline of this approach is, we're working, I work test, retest into it. I want to know, hey, if you do this, you take some quote unquote strain, some stress off the structure, this area of the joint. Do you feel better when you were doing the movements that you were symptomatic with? So that's essentially that's the approach I take with it. And I use that explanation a lot. Even let's say someone who has a painful symptomatic medial knee valgus, right? It's like, okay, we can do a little bit of hip work. We can see how you do with a more neutral knee when you squat, stand up, whatever it is. Okay, we offload that for a certain amount of time. Once they become, much less symptomatic or asymptomatic, then I'm like, hey, do a couple squats. Okay, you got a little bit of valgus, which is fine, probably normal. Hey, does it hurt? No. Okay, start doing that again for the next week. Come back in a week. How'd you do as you were squatting? Add some weight, didn't hurt. Cool. Okay, you're good. Now you know what to do if it does bother you again. Otherwise, you're moving how you're used to, however you want.
It's very interesting because when you pick the ankle, for example, your intervention addresses the ankle directly. Yeah, and then I guess that does change some of the initial definition that I gave, because I didn't consider this, because I thought of it mostly when I think motor control, I primarily think knee and shoulder for the most part.
Yeah, which you would go
at least.
Yeah, which it makes more sense to go distal. Yeah, exactly. Which like you said, for knee, like I don't know, what am I going to do? I don't know, popliteus activity. You know what I mean? No, I got to go up, right, or down. Right?
How many, for real, how many times when you see a knee issue are you like, oh, we need to strengthen that knee? We really gotta just hit the quad straight up. And
from a motor control standpoint.
Yeah, like or
Not too
from a
much.
strength standpoint
I
or
mean,
something like that. I just don't really see it unless it's
nah.
like really
Yes,
deconditioned and
yes,
they're
yes,
just
yes, yes.
weak.
So
Uh,
typically when the cases that I hit quad the most in are like typically older, um like obese deconditioned females. I don't, that's just for whatever reason but that's not even, it's not just quad, it's just like an overall like
it's
lower
general,
extremity
right?
general decondition. It's like, listen, like you can't get up out of the chair, you can't go up a step, like we got to hammer quad and hip. But quad in isolation, yeah, maybe there's certain
Doesn't
athletic
really
populations
happen.
where like, yeah, exactly, like maybe, I don't know, like if it's like a post-op AC, like I don't know, I'm gonna say post-op ACL, but that's such a cop-out answer.
That
It's
is
like,
the
yeah,
that's
obviously,
the
yeah, right.
those are like the only ones where it's like they had a previous surgery, did not have a good rehab, or just
Yeah.
like it was really problematic and their
Hmm.
quads not firing. And they're just having anterior knee pain.
Yeah,
Or
yeah,
if it's isolated anterior knee pain and like they're showing like fair hip control and stuff like that for the most part. And I've tried motor control, I've tried addressing proximal
yeah, yeah,
distally, and I'm not getting any results. Okay, yeah, I have no issues with hammering the quad. That makes my job so much easier.
yeah,
Instead of having to spend all this time observing and then test, retest, and then seeing if things change. Like just hitting the quad makes
yeah,
my job so much more
yeah, for sure,
straightforward, right?
yeah,
I would be down for that any day of the week, but it's just not
yeah,
something that I typically see.
yeah, yeah.
But
Unless
for
it's like
the
unless it's like we'll just say like tendinopathy or whatever it is, like, and it's more of like
true,
a
true.
graded exposure type thing, or like contractile dysfunction where you're just working into that specific movement. But I guess when we're talking motor control under the definitions that we're using, like I don't find I need to like teach someone to use their quad better, right?
Yeah, and it's
Yeah, okay,
usually like
but
a joint issue too,
yeah,
right?
yeah,
Like that
yeah,
you're affecting.
sure, yeah,
Um,
yeah,
but yeah, I think that it's interesting because like there are certain joints where I think Mark and I just from our experience, we're seeing these patterns and it's just like, okay, so we see this, we usually think up or downstream. And then other joints we're like, no, like that's the joint that needs to be hit.
yeah,
Like
yeah,
even for Mark's example for the ankle, you could argue that by doing different foot exercises, you're addressing something that's more distal
yeah,
to the ankle.
like maybe
To
like
me,
yeah, metatarsals or something like that, right?
yeah, if you do like arching or short foot, whatever you want to call it,
Yeah, yeah.
toe yoga and stuff
I
like
don't know what
that.
that is.
I
Listen,
don't
I
know.
still
I
don't know
just
what toe yoga is, and someone told me to do it on their patient. And I said okay, and I don't know.
I mean, okay, so like I just consider the whole foot and ankle complex to be one thing for the most part.
Yeah,
Like
yeah, yeah,
thinking of it in different segments to me is just overly complicating it. So I just group them all together as one thing,
yeah.
treat it as that, and just go on from there.
Wait,
And that's just how
little offshoot here. If someone comes in and they're like, and they're coming for plantar surface foot pain, and do you ever like, oh, like how's your ankle? And like, it's my foot, and I'm like, oh yeah, because I think
I
so,
don't usually ask the ankle. I would usually
okay,
say their foot if it's
okay, yeah,
plantar surface
okay.
pain.
What if it's heel pain? Are you
So
like, how's your foot? And they're like, oh, it's my ankle. You know, you ever get
that
that? You ever
doesn't
get that kind of
no.
stuff? I just
don't usually get that. I think for the most part, people know what we're talking about. I'll
Okay.
usually just say, "How's your foot? How's your heel?" Or
right.
"How's your Achilles?" Or
Maybe,
something along the lines of
must
that.
just be me then. Must just be me. Next time I have a foot or ankle eval, I'm just gonna ask them. How is your insert diagnosis code? Okay.
Oh my god, that would be terrible. But yeah, I think that for a lot of these issues, like looking up or downstream from the problematic area is helpful. It just helps you see how the body moves as a whole. And this is where I think that a lot of people also kind of get lost as well too, and they start looking at everything. And I don't know if this is a trend. This could be another episode on its own, but I'm seeing it pop up more and more and more, and I feel myself getting angrier as I continue to even think about talking about it. But this obsession with hip internal rotation is driving me insane. Why do people care that someone is lacking in a couple of degrees of hip internal rotation? How much does it matter to you? It's just
Listen, dude,
it makes me
it's all
so
about
mad.
it's all about recruiting the inferior fibers of the gluteus maximus. All right.
How like
yeah.
it's okay. So I've noticed this trend in social media where I've seen it more, and I'm finally seeing more and more strength and conditioning coaches come out and be like, why are you telling people that they're lacking hip IR, and why are you concerned about it? For people who have who obviously go to the gym, take care of themselves, they do their mobility exercises, and they're like, no, I'm really stuck here. And then a lot of these coaches are like, well, why does it matter? Are you squatting well? Are you deadlifting well? And not only that, if you're a PT and you're addressing this, how are you addressing it? Are you actually just stretching them and mobilizing them? Are you loading them appropriately? If you load someone into a single-legged RDL or even normal deadlifts, they're going to go through hip internal rotation, right, at the bottom position. That is the whole point of it. If you aren't loading these positions, I don't care if you've restored that motion. It doesn't really do much. You aren't reintegrating it into a pattern. For the
how are they
patient.
going to know how to utilize it?
It just it's mind-boggling to me that sometimes we try to find deficits that aren't problems. We have asymmetries. That's normal. We have differences in how our bodies are meant to move. That's normal. It drives me insane when people create a problem out of nothing. And that's what we're going to focus on now. We don't need to do that. So the reason why I bring that up is because when you're doing motor control, make sure that you are looking at things that are relevant to your patient, that are making a notable change to your patient. And listen, if they're lacking hip IR and you address it and it fixes their issue, so be it. That's awesome. That's great. That's exactly the formula that Mark and I pretty much just presented to you, where it's you find the relevant impairment. But if it's not relevant, please sometimes you don't need to worry about it. You don't need to put it in your patient's head. Just let them continue doing what they need to do.
Yeah, which we talked about in our, I forgot which episode it was exactly, but when people have this gigantic list of quote unquote impairments and there's no talk about the relevancy of it. It's well, this hip's tight and this movement that, and the strength here and strength there and this, and then before you know it, you got 5 or 6 exercises for the home program, and you have 30 different baselines, and everything's just getting measured generally, and it's where is the notation of relevancy? How do you know? Right, what's our focus on? Is there? I mean, I guess there really isn't a focus, and it's just what are we looking to achieve by addressing everything generally versus finding, the most, 1, 2, 3, whatever, relevant impairments that are contributing to the symptoms that the person's having, addressing those, test, retest, and then, it would just made it more simple for everyone and probably more efficient and effective.
I think one of the big things that when you keep things super simple for yourself and your patients, it makes it a whole lot easier for you to be on the same page, and that you're just on the same wavelength and understanding what both parties want. You get what the patient wants, and they get what you want out of them as well too. So this is where the small those details that are harder to detect, to find, and all the different baselines that Mark was talking about, those things, I feel they are usually not the primary contributing deficits. Fix the big overarching problems first, then worry about the smaller things. Those big problems are, and the common ones that you see, those are what's really going to get you 75-80% of the way there, if not more. And I think that getting your patients on board with that is going to be so much better. If you create this issue or over the small deficit for your patient, I think that usually sets them back more because they're just like, oh, I have to worry about this when I do that. And it's just like, no. I just want you to live your normal life. I just want you to do what you've been doing and then see how things continue to change. See if like some of the cues that you've given them, if they stick without having to do a whole lot more. Like I said, it doesn't take a whole lot of change. Sometimes it's just like a couple of things and then boom, they're fixed. And you may not even see a visible change, but the patient sure feels it. And so that's where I'm like, your eyes, your hands, they like I'm very confident in the things that I see and like my hands and stuff. Even for me, I'm like, nah, I can't see that. I don't care. But you feel better. Awesome.
Yeah.
Did we make a change? Maybe not. But at the same time, the patient feels better. I'm happy about that.
Right.
And like, I want them to continue to feel that way. And honestly, like there is a discussion on whether or not this is like, could it be placebo? Could it be a different thing? Maybe you're desensitizing your patient to a movement. Mm-hmm. To me, it really doesn't matter that much. It's like the patient's getting better. That's what I care about.
There's no
I don't
claim
care what you call it.
Yeah, there's no claim being made from, I mean, at least the claim that I think people associate with motor control is that, oh, if you move this way, like maybe there are some like fringe examples of this, but if you move this way, you're less likely to, you're going to reduce your chance of getting injured, or you'll have less arthritis or this, or you're putting less pressure on the disc and you won't have back pain, those kind of claims, right? Like at least the definitions that Kane and I are working under, we haven't made any claims like, hey, if you do this, that this will happen or be less likely to happen in the future. I don't know that we have evidence to say that, if you move this certain way, then you're at a smaller risk for, knee arthritis to become symptomatic, whatever it is, right? All that, from what we talked about today, we're just saying, hey, this person, we know this person has these symptoms in this specific moment. They've had it for this amount of time. They're moving a certain way. We have them move slightly differently or perform a certain exercise. And then the movement that they were previously symptomatic with is asymptomatic or less symptomatic, right? And then we give them the option, hey, you don't have to do this. We don't expect you, and I don't want you to move like this for the rest of your life. This is how these symptoms do come back, this is how you manage it. Which I think is a much more, it's more nuanced, it's more practical, it's just a much more realistic approach to, what we can say is motor control.
Yeah, I think one thing that I wanted to add to that is it's almost like I hate to say it because I don't want it to be taken in this way per se, but it kind of works out is you correct the patient enough to make a change in their symptoms. And you kind of, I don't want to say you overcorrect because I really hate that idea for this concept here, but you correct them enough that there is, even if they regress, that there's still a significant amount of carryover long term to their motion so that way it doesn't come back. I really hate the term of overcorrecting them because it's like over cueing or having them do too much. But as they start to default back more and more to their old movement strategies, it's enough for them to do so without having those symptoms present again. And maybe Mark was right. Maybe we just offload the tissue enough that it that got a chance to chill out, and now they can just go back to how they were doing stuff, and that's okay too. Right. Like, I'm not saying that what I determine is motor control is the right thing or the end all be all. Yeah. This is just the definition in my head and how it kind of works for my patients and in my practice. And I can certainly see the aspect or the perspective that Mark is drawing from too. I definitely agree with it. I don't deny it at all. I think that both are very, very good perspectives to take and to apply to your patients in regards to getting them back and less symptomatic. That's for sure.
Yeah. How about like this is something I was thinking about like when we're preparing for this episode. let's take knee valgus. What if someone, let's say they have, if they're symptomatic, or let's say they're asymptomatic in like a real like extreme valve. I mean, let's say they're asymptomatic in a, a position that doesn't look good, and let's just take knee valgus for example. They squat down, their knees are touching, and they're asymptomatic. It feels good for them. It feels good to them, and that's their like preferred position. And let's say that position even relieves symptoms, like from a motor control standpoint. Are you sticking with that? I mean, I don't know how. This is completely hypothetical because I don't know how often this would ever, if it would ever present clinically. But like, let's say you talked about movement quality and like how it looks. If someone's doing a movement and it looks horrible, but it's good to them, they perform well, that's how they like to move, they don't have pain. Are you training that position?
Or there, that's a
this
a
is kind
can
of like
worms.
like maybe we can save it. I'm not trying to like set you up or anything. It's just like I've wondered about that because I have had people who they go to pick something up and they like their torso's like perpendicular to the floor, and it's just like, you're not gonna, how are you gonna, I don't know, it's just like, you ever try like bending over a little bit, you know what I mean? but and they're like, this is fine, it feels good, and I load up like a box with like, I don't know, 75 pounds or whatever, and they just need to be able to pick up like a 20-pound like box of fruit for work or something, and they're like, yeah, no, this is good. And I'm like, okay, yeah, it sounds good. I mean, knees feel fine, back feels fine. They've been exposed to the hinge position, but they just don't like it. So I'm like, all right, keep doing it this way. It's presented a lot. Like, I haven't seen it a lot, but I've wondered about that too. It's like, I just really like, I want you to hinge at your hips, I want you to bend your knees. I just want you to use your glutes, use your erectors, get into it. But they do it differently, and I guess that's fine. Like, have you seen any examples like that?
Yeah, I have. And it's kind of across the board where like
Yeah.
I usually say that these people just don't usually have the best movement strategies.
Yeah. Just generally, like that they don't. Yeah.
And like it's definitely, like I said, it's a can of worms. Like usually for the patient that Mark was describing in the beginning, which is like a lot of knee valgus, and they don't have any pain or anything along the lines of that. If it looks really bad, I may try to make some small changes, but that is largely going to be based on the deficits that I'm finding. If they have like zero glute activation or maybe no quad activation when they're doing that pattern, I may try to change some of that pattern down the road. I'd want to address their deficits first, see how they continue to move, and sometimes their pattern improves just because they're stronger.
Yeah, and you're just testing it. You're just testing. You're just like, hey, let's just see what happens if you do this, right? Even if they don't have symptoms, even doesn't. Yeah, but it's not like you're not like, hey, yeah, okay, so finish. Yeah. Just like, hey, maybe let's just try it, and maybe it feels even better than what they thought felt the best for them.
Yeah, and this is why, like, when I say like the cookie cutter approach doesn't work, there is a spectrum for where people need to be. Like, some people will move more valgus, some people move with more trunk lean, and both of those are fine options, but it's like within a certain realm of acceptable. But if you're outside of that realm, that's where I will check different deficits, and then I'll see if different like small changes are going to make improvements for you. And if it does, that's awesome, right? Like, that's our job. That's what we're supposed to do. But if I try to make those changes, I make their symptoms worse. They don't get any better. They're like, I don't like this. I can't do it. And their deficits are gone. Who am I to change that? Maybe that's just how they are.
Yeah.
Their tissue has adapted to it. They've been doing it for like their entire life. Like, I am not someone who's going to change all of it just for the sake of changing it and to make me feel better, like I did something.
Like you said, PTs want to provide. They want to, So, but like you said, you got resisting that urge and taking the individual, as they are is, really what you think, what I think PT should be doing.
For sure. And I definitely agree with that. I think for the second example, I am much less likely to correct it though. If someone has like issues with picking something up, then I'm just like, okay, like that's how you lift stuff. That's how you lift stuff. You know,
Yeah,
like you don't have
yeah.
any pain, no issues, run with it.
Mm-hmm. Cool. Anything else you want to add, Kane?
No, I think there's
That's a good
plenty
one.
of stuff I'm sure that we can
Yeah.
add, but I think that it's going to be better for another episode. We had a lot of stuff that we could have branched off onto today.
Yeah, exactly. And I think we'll build on our following episodes. I think the motor control topic will kind of work its way into some of them coming up. But okay, well, just summarizing today was about motor control. We had our working definitions of it, essentially implementing different exercise or temporarily altering movement to aid in performance or to reduce pain, just help people move better. We want to emphasize that we don't believe every single person needs to move the same way. We're not robots. Yet everyone's built slightly differently, and what works for one person may not work for the other person. But we think PTs have a role in aiding when it comes from a movement standpoint in aiding performance and reducing and eliminating pain. So that concludes today's episode of the PT Good podcast. Remember to leave a like, subscribe to us on whatever platform you're listening to us on. Follow us on Twitter at PT Good Podcast. Thanks for listening. Hope you enjoyed. We will see you on the next episode.
Misty, love you. Bye.